Great. Hey, guys. Good afternoon. I'm Joe Bosco, and thank you for coming or logging on to this webinar. So today we're going to spend the next hour or so discussing bundled payment and alternative payment models and the 7 pillars of bundled payments, orthopedics and beyond. So as we all know, or maybe we don't know, that there's a disruptive change heading our way. And like any other disruptive change, I think it's an opportunity. You know, I think of it as you know, late in the Cretaceous period when this big old meteor was heading towards the Yucatan Peninsula, and you know, the big T-Rexes and the dinosaurs that ruled the planet had no idea what was happening. And this little mammal here, those are the people that, you know, those are the guys that survived. And you know, we want to be the survivors. So anytime there's change, disruptive change is opportunity. I think this is what alternative payment models are, a disruptive change. And if anyone thinks out there that this is going to be affected by who wins the election or politics, that's really not true. This is all agnostic to politics, whether you're Democrat, Republican, whatever your political leaning is. These changes are going to occur. Everyone agrees that they need to happen. So basically, you know, those who accept and understand these changes are going to be winners in the healthcare environment going forward. So as we know, you know, the rise in healthcare spending in this country is not sustainable. In 2 or 3 years, healthcare spending is going to be about 20% of the GDP, and that's basically too much. You know, it's bankrupting our country. Also, if you look, we spend, and this is an older slide this year, it's $10,000 per capita on healthcare, public expenditure. Whereas as you look at like Spain and Japan, they're down around $3,000. So when some of our companies go to sell tractors against, you know, compete with, or cars, compete with Japanese car manufacturers, they can't compete because, frankly, you know, what the companies have to pay for healthcare for their workers is just too burdensome. So that's why, you know, whether you're a pro-business or anti-business or Democrat or Republican, you really understand that the healthcare is too expensive and is really causing problems with our country. So along came this guy, Michael Porter, who understood that value in healthcare is outcomes divided by cost. And I think that's an important concept to understand. So what this transition is it's a transition for fee-for-service to value-based care and value-based payment. And what, you know, as Michael Porter said, value is outcomes divided by cost. But what's not acceptable is to decrease costs but affect outcomes in a detrimental way. So theoretically, you know, if you know third grade fractions, you know that if you decrease costs by 50% and decrease outcomes by 10%, you've added value. But that's not tenable in healthcare. So basically, any kind of cost decrease can only enhance or unchange value outcomes. It can't make it worse. So, you know, this value-based payment now is really going to oversee or take over traditional fee-for-service, we think. And the issue is a fee-for-service. There's no care coordination with fee-for-service. The doctors don't talk to each other. There's poor communication between providers. You know, basically, the more charges, the more people make. So, you know, if I do a knee replacement and it gets infected, we have to readmit the patient in 30 days. The hospital gets to bill for that readmission. I get to charge for taking care of the infection. So basically, although no healthcare provider would ever do this on purpose, the idea is that the more complications you make, the more complications you have, the more you can bill, the more money you make. So it was a disincentive, I think. So this was not value-based care. This is fee-for-service, and that's coming to an end. And again, you know, when you look at ways to decrease healthcare expenditures, you can try to decrease healthcare expenditures by limiting access to care, especially Medicare patients, or raising the age of Medicare eligibility from 65 to 70. Well, that's not tenable. Anyone who does that will not get elected. But everyone can agree that, you know, why should we pay for bad care? Why should we pay for complications? You know, so value-based care is here to stay. So along came Sylvia Burwell. She's current head of Health and Human Services. In 2015 in New England Journal of Medicine, she stated publicly that 85% of Medicare fee-for-service is going to be tied to quality and value by 2016, and 30% of all Medicare payments are associated with APMs, with advanced payment models, alternative payment models, and in 2016. And unlike most government programs, they're actually ahead of schedule. I think in 2016, over 35% of Medicare payments are associated with alternative payment models. So the government's actually doing ahead of schedule with this. So what's the evolution of value-based payments? You know, it all started probably about 8 to 10 years ago with pay for performance, and I think all of us out there are familiar with that. That was like, you know, value-based payment 101, freshman level course, if you remember college. And basically, you're rewarded for meeting metrics. There's no downside. You got rewarded if you did certain things. For instance, like if everyone got antibiotics within an hour of their surgery, and you were above a certain percentage, you would get a little bonus from a healthcare company. And I put skip lines, that guidelines, that surgical care improvement program. That's a lot of those guidelines were such that they were counted as metrics. The problem with these is that everyone mastered them pretty quickly. So the high achievers would get 99.9% on these, and the low achievers would get 99.2%. And the other thing is that these metrics, there's no downside if you didn't do it, and B, there's a tenuous link between these achieving these metrics and actually better outcomes for patients, right? The link was not established. So that evolved to Pay Performance 201, which was based on actual outcomes, not just processes of care. And these are patient-reported outcomes, things like HCAP scores. So you actually had to show that what you were doing for patients was improving their care. So that was, and there was still no downside risk to this. It was all upside risk. Then, you know, the junior level course, Pay Performance 301, included downside risks, things like readmission penalties, the government's value-based purchasing program, where there's, you know, certain hospitals get dinged for if their readmissions are too high, and then they get a little bonus if their readmissions are lower than average. So that's Pay Performance 301. You know, there's upside and downside risks. So now, what's alternative payment models? These are really the final evolution of pay for performance, we think, and it starts with bundling payments, and we'll talk about what that is. And then it may go to capitated care as well, where there's one patients get per month per patient money. So their providers will get a certain fee for all the care a patient gets for a certain time period, and it's the provider's responsibility to parcel out that care. And examples of capitated care organizations are ACOs, Accountable Care Organizations, and PCMHs, which is a patient-centered medical home. We'll go through these individually. And there's all you guys out there should look on the internet and look up the CMMI, which is the Center for Medicare and Medicaid Innovation. That's a government program where a bunch of smart people in the government are in a room, and they're thinking about ways to innovate for healthcare. And they probably have about 60 different ideas. And I look at it as like akin to throwing spaghetti up against a wall. You know, some of them are stick, some of them don't. And the ones that are stuck is bundled payments and ACOs and patient-centered medical homes. So, you know, this government agency was charged with develop new payment and service delivery models. And the website's actually really fascinating to go to. So now you have the government really full force behind alternative payment models. Sylvia Burwell on record in New England Journal of Medicine saying that by 2016, 30%, by 2018, 50%. And then the thing that really has nailed this down is MACRA, which of course is replaced the SGR, how doctors get paid, right? There was a sustainable growth formula, which was outdated and broken. So for years, physicians were screaming that we need a change. So what they did was they got rid of that and enacted this thing called MACRA, which is Medicare Accessibility Child Health Insurance Plan Reauthorization Act. And what they've done is they've given physicians a little bit of increases every year, but they tie these increases to performance. And really they're pushing physicians into APMs, and this is why. Because what they've done is, and again, I don't want to get into too much jargon, but the performance program they've made is called MIPS, which is Merit-Based Improvement Program. And it has a bunch of different metrics: quality, resource use, all these other things. And in 5 years, you could be plus or minus 9% as a physician based on how you do on this, which scares a lot of people, and it should, because there's going to be winners and losers. Or if you don't want to be in MIPS and expose yourself to plus or minus 9%, you can join an APM, which is alternative payment model. And if you're in an alternative payment model, you get exempt from MIPS, you get exempt from that plus or minus 9%, and you get a guaranteed 5% bonus every year, which is pretty good. And that's why most physicians now want to really join an APM, because they'll do anything to avoid being in this merit-based improvement program, because it's really, plus or minus 9% is sort of daunting to people. And plus, frankly, if you're in APM, starting in 2021, you get a 0.5% raise every year to your base. Whereas if you're not in a APM, you're raised every year at only 0.25%. So basically, the government is doing everything they can to push physicians and providers into alternative payment models. So the one that we're going to discuss more is bundled payment arrangement, right? And a bundled payment arrangement is a single payment to providers for all healthcare during a certain period of time. And what happens is the providers assume a financial risk. So if they come below a certain number, they get to keep the difference. If they're above a certain number, they have to pay out the difference. And that important concept is the episode of care. And that's a time period over which a bundled arrangement exists. So for instance, total joint replacements, the episode of care is the hospitalization plus 90 days post-discharge. So that's the episode. And bundled payments have been around for a long time. There's a federal government, there was a bundled payment for care improvement, BPCI, which is voluntary bundles, which started in 2013. There were over 400 entities which participated in this, from things. Total joint replacement was the most popular one, but there's all kinds of procedures, cardiac valves, everything. And this was very successful, so it morphed into a mandatory program called the Comprehensive Care for Joint Replacements, CJR, which is mandatory beginning April 1st, 2016, to 1/3 of all hospitals which perform joint replacements. And now there's a new mandatory federal government program called the SHAFT, or Surgical Hip and Femur Fracture Treatment Bundle. And that's going to start in 2017. And also, 2 months ago, they started a new cardiac bundle, including MIs, cabbages, and valve replacements. So, bundle payments expanding. Any of you out there from Arkansas understand that in Arkansas, for 5 years, they've been doing bundled payments. And in Arkansas, 1/3 of the patients have Medicaid, 1/3 of the patients have Medicare, and 1/3 have private commercial insurance. So it's a small state. The governor got all three representatives of all three insurers in the same room and said, we're going to bundled care. And they did. So when you do a total joint in Arkansas, whether it's Medicaid, Medicare, or commercial, you're in the same bundle and you get paid the same amount of money for it. And they've also done things like CHF is in this bundle, ADHD, attention deficit hyperactivity disorder, having a baby is in this thing, so it's all around. Also, there's commercial bundles. So private practitioners are groups of orthopedic surgeons are doing their own bundled payments, going to employers and say, we'll do all your total joints for a set amount of money. So bundled payments have been around for a long time. And one thing that's caught a lot of providers and hospitals' attention, what happened in California when they looked for when they went to a single price for joint replacement surgery. Basically, CalPERS, which is the insurance company for retirees in California and covers hundreds of thousands of lives, said, here's the deal: we're going to pay $30,000 for a joint replacement episode. And there were hospitals which were above that and hospitals which were below that. And they said, if you go to a higher price hospital, you have to pay the difference. If you go to a lower price hospital, then you don't have to pay any difference. So what happened? Everyone started going to lower price hospitals. So the CalPERS high price hospitals lost volume. The CalPERS low price hospitals gained volume. And there was no change in the quality from the lower high price hospitals. That's the most important thing to understand, is that the quality in these low-price hospitals was the same as the quality as high-price hospitals. But once they went to reference pricing, where insurees were getting X amount of money and they had to spend it where they wanted, they went to the low-price hospitals as long as the outcomes were good, the outcomes were fine. And when we compared it to Anthem patients, which were not in this program, the volumes didn't change. So it really scared a lot of people. So that's a little bit of the background, but this stuff is here to stay. Now we're going to transition a little bit and talk about the 7 pillars. And we'll start with the first one, which is coordinated care throughout the episode. And what's the importance? It enforces best practices, standardization of pathways, workflows, and order sets, improves communication with providers and the patient, ensures aftercare and follow-up after care transitions. There's a lot. How many of you out there in the audience have had loved ones or themselves been discharged from the hospital without any good instructions, without the right medications, right? So these care transitions are areas where a lot of errors occur. They optimize patients' expectations, optimize the patient. So again, it starts from preoperative care, bundle does, during the hospitalization, and extends to postoperative care. So we prepare patients for the inpatient settings and this is what we do for total joint replacements, which are in a bundle. A care coordinator is a nurse, calls the patient once they're scheduled for surgery, develops a relationship with them, sets expectations for the hospital stay. Mrs. Jones, you'll be in the hospital for 2 days. Also understands the risks, so understands whether they're a high or low risk patient, so they can apply the right risk strategies towards them. Lets the patient know that after their discharge, they're going to go home and not to a nursing home or a nursing facility, which is very important. And they're there to create smooth transitions. So we have interdisciplinary rounds on a daily basis to make sure patients are on the correct pathway, make sure they're not deviating, addressing problems when they come. We have weekly care coordination conferences, which review our data and make sure that there's no issues ongoing. And again, we set our expectations for length of stays with our subacute rehab places and our nursing facilities. So what happens after discharge? Our same care coordinators follow those patients after discharge. And what they do is what that does is it reduces readmissions, because they're constantly calling them every day, every other day on the phone. Is everything okay? Making sure if there's any issues, it doesn't rise to the point where they have to go to a local emergency room, because that's what you want to avoid. Because when a patient goes to a local emergency room, then they're going to get readmitted, and that's when you lose control of that patient, right? And that's when disorganized care occurs, because they're not with any of their providers, they're going to a local emergency room, and bad things can happen there. So we also track readmissions on a real-time basis. So again, patient navigation from pre-admission to hospital to outpatient is all overseen by a nurse care coordinator. And they do it by electronic methods, emailing, by telephone, by fax. You know, CJR, the government's program for mandatory bundling, has really given its imprimatur to telemedicine. They've made a lot of exemptions for telemedicine, and there's a lot of companies out there that have programs out there that can give you platforms where your patients can communicate via secure email and the web, so you can monitor their progress. I mean, there's programs out there, many of you guys know, like for CHF, congestive heart failure, where, you know, patients will be sent home with a scale that's wired to the Internet of Things, right? So when a patient gets on the scale every day, that weight gets transmitted to a website so it can be monitored. Because with CHF, if people start gaining weight, that means they're retaining water. And if they don't weigh themselves that day, they'll get a phone call, how come you didn't weigh themselves? Same thing with glucose monitoring. You know, they check their glucose, that automatically gets sent to a website where their care coordinators can look at it. So basically, you're leveraging technology to track these patients. So this is a slide we have to memorize. No, we don't have to memorize it. But this is all care coordination throughout the continuum of care, from pre-hospital to inpatient to post-discharge. And there's a lot of things people have to do, right? But the important thing is they understand the patient before surgery. They understand the risks. In inpatient, they make sure they're on the right pathways. And outpatient, they continue to follow them, make sure they're not readmitted. And so the challenge really is to maintain a seamless transition. That leads us to the second pillar, preoperative identification and modification of patient risk factors. Because if a patient's going to have a problem or at risk, you want to know that before they hit the hospital, not after. And there are certain risk factors which can be modified. And it's important to stratify these risks. Why? Because the patients that have the highest risk, you can give more resources to. For the patients that are lower risk, you can give less resources to. So that way you optimize your resources. The other thing is we think that at some point there's going to be risk stratification, which is basically high-risk patients will be given a little bit more money, sort of like CMI, case mix index. So identifying high-risk patients for shared decision-making, which means that we know, for instance, that if a patient is morbidly obese, smokes cigarettes, diabetes out of control, and has staph in their nose, they have about a 15% risk of developing a postoperative infection after a joint replacement. So if you talk to these patients, they may elect not to have their joint replacement, or they may elect to modify the risk factors, stop smoking, get their diabetes under control, lose some weight before having that thing. And also, we're ethically able, it's within our ethical purview to delay surgery on these people. You don't have to you don't have to perform elective surgery on everyone who walks in your door. Not that you want to do lemon dropping, which is basically not take care of sick patients, or cherry picking, only take care of healthy patients. But certainly you can delay a patient's elective surgery while they modify their risk factors. And this is something that this is our readmission score, something we made. These are risk factors. So we know if they have all these risk factors, they're at a higher risk for readmission and a higher risk for infection. So again, understanding the risk. And this is our readmission rate, our 90-day all-cause Medicare total joint readmission rate. It was up to, when we first started, about 15%, and it's gone down to 6%, which most people think is high, because I guarantee you if you ask your orthopedic surgeons what their readmission rate, they'll say 2%. But that's maybe 30-day readmissions, that's all patients, that's only reasons attributed to their joint replacement. What the government looks at, 90 days, all-cause readmissions for Medicare patients undergoing total joint replacement. So it's a lot higher than you think. So here's some of our interventions for our modifiable risk factors. We do MRSA screening and discolonization in noses before they hit the OR. We do hepatitis screening, smoking cessation. We delay their surgery and put them in a smoking cessation program. We look, we avoid, we understand drug and alcohol dependence, screening for DVTs, all these things. Again, the idea is that these risk factors have to be known beforehand so they can be addressed, modified, and or compensated for. Okay, so that leads us to the third pillar, which is evidence-based clinical pathways, right? So now, there's not just one right way to do things. There's several right ways, but there's known clinical pathways which people should be on, right? And we have 30 different surgeons that do joint replacements at our institution, and they're not all employed physicians. So everyone doesn't do everything the exact same way. We have certain evidence-based pathways that we make our surgeons follow. And if they don't, they're counseled because, frankly, it's the right thing to do. So standardization of care decreases physician-specific variation, right? Anytime you look for performance improvement, what's the first thing you look for out there is variation. The other thing is these evidence-based clinical pathways, you could share them with other low-volume hospitals. These clinical pathways take experience, right? We'll talk about that. They're hard to develop, but there's no reason why you can't share them with lower volume hospitals, right? So they can provide their patients with better care. Things like, and we're talking about is post-operative labs, blood management, pain pathway is very important to have an integrated pain pathway. We try and decrease the amount of consultants we use. We screen people for VTEs. And just one example is the multimodal pain management pathway. We think this is crucial for bundled payment success. It decreases length of stay. Patients feel better. Their functional recovery is much better, and they're more able to go home. And again, we try and avoid narcotics if at all possible. We haven't done a narcotic-free joint replacement yet, but we get rid of PCA pain pumps, give people oral long-acting narcotics. We use periarticular injections with liposomal marcaine, which we feel is very important. And what that does these periarticular injections and cocktails we give obviates the use of blocks. So we don't do femoral nerve blocks anymore. And what's wrong with the femoral nerve block? People fall in the hospital, right? And every hospital administrator knows, and nurse knows that falls are a metric for quality. So if you have a lot of falls, that's not good. So, we really put people on an enhanced recovery protocol. Blood management is another important thing. There's a lot known about blood management now. Transfusions are bad for people. They're expensive, and more importantly, they increase your risk of infection. So now we know that we don't transfuse patients unless their hemoglobin goes below 7, which is a big deal, or they have active bleeding, or they're having chest pain. But basically, that and the use of TXA, tranexamic acid, which is basically a generic product, costs about $10, has really almost eliminated the use of transfusions and unilateral joint replacements, especially knee replacements. Again, this is very important because transfusions are expensive and they're bad for people. So when you look at that Michael Porter's equation, right, value equals outcomes divided by cost, avoiding transfusions improve outcomes because they don't get many infections and decrease costs. So that hits that equation on both ends, which is very important. And so again, we also looked at our VTE prophylaxis and basically customized VTE prophylaxis for patients' risk factors. And that's also been a boon to us in terms of saving money and improving outcomes. And we talked about pain management afterwards. So what we learned in this thing is that if you have a multimodal pain management pathway, if you avoid blood transfusions, if you give the right VTE prophylaxis, if you do all these pathways, patients will have better outcomes and you'll save money, which is what we want to do. Which leads me to the fourth pillar, which maximize and demonstrate quality. Not only do you have to maximize quality, but you have to be able to demonstrate your quality, right? So those of us that deal with quality and quality metrics know there's probably a whole alphabet soup out there of quality metrics. But it's interesting now that in the last year or two, the government and payers have begun focusing on a few. And what are the few? They're HCAP scores, patient experience, patient-reported outcomes, and also this one NQF is National Quality Foundation, and they're the ones that approve these outcome measurements. And there's hospital-level risk stratified complications rate, or RSCR. That's part of the comprehensive joint replacement bundle. So that's a quality metric, which is NQF 1550, if you really want to know. And that looks at VTEs, mortality, SSIs, falls, fractures, following joint replacements. It's hospital level, and it's risk stratified, but it's a very important metric, and it's publicly reported. So these are the metrics that hospitals need to, hospitals need to understand, do well on, and be able to demonstrate their improvement on. These are our readmission rates, and it's interesting to see this up here, because at our hospital we did cardiac bundles as well. And so cardiac bundles, cardiac valves have a very high readmission rate. Because if you have CHF, you get a valve, you're still going to be in the hospital. So it was up to 39% at 90 days. We started off at 13%, and we got down to about 8%, which is about 40% decrease, which is pretty good for us. This is joint replacements, purple. Medicare joint replacements in the purple. These are cardiac valves. Okay, so we'll just go. So performance metrics are also tied to how much money people make, because when you're in a bundled care payment arrangement, it's not good enough to save money. Saving money, you'll get a portion of that money saved if and only if you reach certain quality thresholds. So you can't save money by giving poor care. We talked about that initially, right? Any change in value has to be, or any change in cost has to be accompanied by either higher quality care or the same quality care. So again, these are the three performance metrics which CJR is following, right? Hospital level risk stratified standardized complication rates, 50%, hospital HCAPs, 40%, and PROs, patient reported outcomes, 10%. Okay, so again, number 5, establish a robust data collection and dissemination infrastructure. Why is this important? Because when you're in a bundled program, especially a retrospective bundle like the government's doing, for instance, when we were in BPCI, or if you're in CJR, if your bundle begins January 1st, 2014 and ends January 4th, 2015, you don't get the data for that bundle until probably 3 months after it's ended. So if it starts January 1st, 2014, you'll get the data for that bundle sometime in March or April 2015. So if you rely on the government to give you that data, which is quite accurate, it's 15 months, sometimes 12 months after the actual time it occurs. And at that point, that data is not actionable. So if you have a problem with infection rates or readmission rates, and you find out about it 15 months afterwards, it's too late, right? So can't rely on the government to give you that data because it takes too long for them. And so like any kind of competition, the people that have the best data and the best information will be winners. So you want your hospital to have accurate, transparent, and actionable data that's in real time. So you can't wait for the CMS reconciliation to figure out how you're doing. And it's got to be physician-specific, institutional-specific, and it needs an infrastructure to operationalize this. It requires an organizational commitment to get this data to the physicians. So again, how does retrospective bundling work? We've talked about that, right? Basically, when a patient is admitted to a hospital, it triggers a bundle. It's flagged by CMS. CMS, at that point, starts tracking how much money it costs that patient. But all bills, all surgeon's fees, all DRGs are paid as normal. And then at the end of the target price, CMS knows how much it paid and knows how much the target price is. And if you're below the target price, they'll give you some of your money back. If you're above it, you owe them some money. That's how it works. But that reconciliation happens at least 3 months after the bundle's over. So you can't wait for that 3 months to figure out you owe a lot of money or figure out you're not doing well. Again, so that's why it's important to have real-time data that you can alter your performance with. The other thing is you need pillar number 6, control the post-discharge care and cost. For Medicare bundles, that's really quite important because when you look at the outcomes of Medicare bundles, whether joint replacements or any of them, it's all about decreasing post-discharge costs, right? So how do you do this? You enhance your post-discharge surveillance. We talked about getting clinical care coordinators to help you out. You establish appropriate level of care, which means that some patients need a higher intensity of care when they're discharged. Some patients need a lower intensity. In order to do that, you have to understand risk stratification, which we talked about. And the RAPT is a readmission stratification score, which we published. Appropriate discharge destination. Most patients can go home with services. You want to avoid sending patients to inpatient scenarios because the quality is not as good and the outcomes are not as good and they cost more. And you can leverage technology we talked about, web-based or phone-based programs to look at CHF or diabetes mellitus or joint replacements. And you have to change provider behavior to control discharge. So the message from the physician has to be, Mrs. Jones, if you're having joint replacement, post-op day number 2, you got to go home. And then those of us that take care of patients like I do will invariably get, well, Mrs. Jones says, Dr. Bosco, you did my hip replacement 3 years ago and it's perfect, and I went to rehab for 3 weeks. Or you took care of my neighbor and she's doing really well, and she went to a rehab place. I need to go to a rehab place because I can't take care of myself at home, which engenders the conversation, yes, you can, we'll provide you services, but that message has to be given in a clear way, and not all physicians are good at that. That's why you have to have other people help them with that. And this is what we're talking about. This is the cost of our bundles, a 3-year baseline period, and this is basically where they go home. The 90-day bundle for joint replacement. If they go home, or they go home with home care, it's about $22,000. If they go to a SNF, which is a nursing facility, or inpatient rehab, it's up to $40,000. So there's a big difference in the cost. And that difference in cost comes with worse outcomes. So it's actually, patients do worse if you send them to a rehab place. They end up higher readmission rate and higher infection rate. So again, that discharge scenario works on both sides of the value equation, right? So if you send them home, you're improving their outcomes and saving a boatload of money. If you send them to a rehab place, their outcomes are worse, and it's costing you more money. So it's another thing where you're really important. Now again, what you do, you can't send 100% of your patients home. Maybe we send 80% of our patients home. And these are the graphs. When we first went into the program, starting in 2009. We started the program in 2013. When we first went into the program, over 80% of our patients were going to inpatient rehab. Why? Because that's where we did business and it was profitable. But now only 20% of our patients, or 22% or 23% are going to inpatient. Most of them are going home. That's the only way you can do well in these bundles. We were in a spine fusion bundle, didn't do quite as well, did a little bit better. We decreased the home thing. We talked about cardiac valve bundles, right? So again, more patients are going home, which is important. These are our results for our bundled payment for joint replacement, and our results mimic basically what happened nationally. If you look at the Lewin Group, they published their national results with bundled payment, and it's the same thing. They saved about 15%, and it's all of that savings in the post-acute care. So we saved 17 or 18% for us. And it's all because of our post-acute care. And this is probably one of the most important slides. So each vertical line represents a patient, right? And this horizontal line is our target price. So for every patient below the line, we made money on. For a patient above the line, we lost money on. And the different colors of this line represent the cost. And this is the index admission. That's all the index admission. Most of the index admission is all about the DRG, which is the same. That's why it's very constant, right? You get professional fees, Medicare Part B fees, which are not included in the index admission. That's including surgeons' fees, anesthesiologist fees, consultants' fees, right? You get things like DME and other things. But you notice that anywhere here in yellow is where they went home after their surgery, right? Anywhere in this rust color when they went to an inpatient scenario. So it's very hard to make money if they go to inpatient scenario. You see all these rust-colored things or orange things on the right-hand side, and reds are the readmissions. It's almost impossible. We have a couple of readmissions we did okay with, but most of these readmissions caused us to be above the threshold. Some of them were way above the threshold. So this is very important to understand. Again, this is what the national experience is. It just mimics our experience. It's all about post-discharge scenario. So pillar number 7 is align and identify stakeholders. There's a lot of people, a lot of hospital and healthcare providers which have a key into managing a bundle. It goes from nursing to physical therapy to social work to anesthesiologists to the surgeons to the people that work in the nursing homes. So these stakeholders have to be aligned with the hospital and other providers. And gain sharing, which is basically sharing the profits from a bundle care agreement, has basically gotten its imprimatur and gotten a wholehearted endorsement from the federal government. The federal government and CMS has always been very gun-shy about gain sharing because they thought it was an inducement to do volume. And every hospital CEO knows one of their buddies that's still in jail from some gain sharing agreement. They have a Medicare patient with physicians, but gain sharing is definitely allowed and actually encouraged within this. So here are the multiple stakeholders we talked about. This the hospital administration, because they would pay the bills for the infrastructure, therapy, social work, consultants, attending physicians, anesthesia. Alignment, very important, right? Everyone has to be pulling in the same direction. As I said before, gain sharing is allowed with physicians. We gain share with the orthopedic surgeons. The gain sharing has to be within these limits. It can't be more than 50% of their fee. It has to be actually associated with actual surgeries they did. It's got to be electronic. It can't be cash in a bag, and it has to be linked to outcomes again. So if a physician has poor outcomes, they can't participate in gain sharing. So that basically concludes my talk. I know I've talked for a long time, but I think in the next 15 minutes or so we can just I'll open it up for questions. So fire away. And
thank you, Dr. Bosco, for that fantastic presentation. Like you said, we will now begin today's question and answer session. So for all the audience members, please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. And we're going to try to get to as many questions as we have time for. There's already been several questions that have come through, so I'll just begin with the first one. and it is, can you talk to payment process? I understood that MDs were still paid fee-for-service on the bundle and then reconciled later. That seems problematic in terms of incentivizing MDs and for hospitals to try and carve back money after the fact. Can you clarify?
Yeah, actually retrospective bundling is the easiest. If you're in a commercial bundle, then you have to be the bank, right? You have to pay the physicians at the time. You have to pay the implant manufacturers. So retrospective bundling, the government pays everything like it is, and then after the fact, they reconcile with you. So you could change physician behavior quite easily, especially if they're gain sharing, right? But there is, I understand about clawbacks. So for instance, there's not a lot of clawbacks to do here, but if you do for readmissions, you can, not all readmissions count against your bundle, right? If 2.5 months or 75 days after their discharge, patient gets diagnosed with a lung tumor, that has nothing to do with your surgery. So that can be, and if that mistakenly gets put in your bundle, you can controvert that and get it taken out. So that's important because then that will get added to the next year's bundle. So you can controvert certain number of the readmissions. Otherwise, the government's numbers and facts are usually very accurate. They have terabytes and terabytes of data. They can tell you within the penny how much each physician paid for, how much they paid each physician, or how much they paid the providers for the whole episode. Hope that answers your question.
Thank you, Dr. Bosco, for that clarification. And the next question is, I just saw an article that indicated that CJR had a cost reduction primarily from post-acute care, but they found that spine surgery saw an increase of about $3,500. Can you discuss the variation, even if that number is incorrect?
Yeah, so we had the same experience. So for the it's not CJR, it's a BPCI, Bundle Payment for Care Initiative, and you had 30 different orthopedic DRGs that you could join if you wanted to, and another 20 or 30 different DRGs were non-orthopedic. And lumbar spine fusion was one of the DRGs which we joined, which we went into, and we dropped out because lumbar fusion is too heterogeneous, right? So they lumped all these lumbar. So there's a big difference between a 1-level fusion and a 10-level fusion. There's a big difference between a simple posterior fusion from a front and back fusion. Also, so not only do fusions differ by the amount of levels, but they differ by, they also put revisions in there. So if you have a revision lumbar fusion that was in the bundle. So we found our cases were too heterogeneous. So that was sort of what we call the radioactive bundle, because it was impossible to do well on, because we had too many cost outliers. And when we looked, and for our institution, when we looked at our baseline period, we fused an average of 4 levels. When we looked at the performance period, which is 2 years later, our average level of fusions went up from 4 to 6. And when we looked at our baseline period, about 8% of our cases were revisions, and that increased to 14% during our performance period. So not only are lumbar fusions heterogeneous, and there's not a lot of, which is not great for bundling, but also the way we practice changed, evolved, right? So look at a total joint replacement. You still do a total knee replacement the same way you did 5 years ago. There's some advances, but it's still the same thing, right? And one total knee replacement is very similar to another one. So there's not the heterogeneity, and we haven't changed the way we practice. So the way they have this lumbar spine fusion bundle set up right now, it's nearly impossible to be successful with those things. So that we call that the radioactive bundle. In our institution, we did really well with total joint bundles, like everyone else did. We did okay, we did okay with cardiac, not as well, but okay with cardiac bundles, and we failed with spine bundles. So we had the infrastructure to be successful. We weren't only successful in orthopedics because we were successful in cardiac, but there's just no way you can be successful in the lumbar spine bundles where they have them the way they have them organized.
Thank you, Dr. Bosco. That's very helpful to understand. And the next question is, how many RN care coordinators were added when you went live with BPCI? And do they have other responsibilities like running the outpatient clinic, etc.?
No, they don't, and they're very expensive. And we started out with 2, and now we have 5. And these are nurse practitioners, and nurse practitioners demand high salaries. And they're worth it. I'm not saying they're not worth it, but they're expensive. So when we first started this 6 years ago or 5 years ago, there wasn't these internet platforms, right? So now we have one clinical care coordinator tracking 200 patients at a time. But with these internet platforms that you can use, and there's a lot of companies out there that provide them, you can leverage that so that one clinical care coordinator can track, now instead of 200 patients, they can track 500 patients. So it's a little bit more cost effective. But that's what I'm talking about when you look at the investment infrastructure that a hospital has to make. Now, I've given a lot of talks and talked to a lot of done some consulting for some hospital C-suites. So this is the typical pushback you get from the hospital CEO or CFO. Okay, we do 1,000 total joints at our hospital, of which 40% are Medicare. It's 400, of which only half of those of that 400 are Medicare fee-for-service. So we talk about 200 joint replacements. So we're not going to invest all this money into doing this. But the thing they have to understand is that bundling is here to stay, right? And bundled care is expanding to non-orthopedic and other orthopedic issues like the surgical hip and femur fracture. So if you develop expertise in bundled care and invest in infrastructure, that's going to have a trickle effect. It's also going to have a trickle effect to the non-bundled patients, the commercial patients that aren't in bundles, because the clinical pathways and the care coordination and the improvement in quality and the metrics that you demonstrated in the bundled patients still get applied to the non-bundled patients. So I think that's the kind of thing you need to have.
Well, thank you for that clarification. And the next question, an audience member wants to know, can you get out of CJR if you are taking part in other bundles?
Yeah, if you're in PCI, you get a 2-year exemption. But it's only got to be, if you're in BPCI for joint replacement, you can get out of CJR for the next 2 years anyway.
Great. Well, thank you for that. And we'll just move right along to the next question, which is, within a group of orthopedists, did you utilize existing staff or hire care coordinators shared within the group?
No, the hospital hired care coordinators, and they're shared. That's my answer.
Okay, great. Thank you. And kind of switching topics here a little bit, this audience member wants to know, what are the average percentages of the bundle going to professional fees versus technical fees?
Yeah, so, this is sort of, and I'll say it, you should never feel sorry for orthopedic surgeons, but we look at, these bundles for the average 90-day episode of care for a joint replacement without major comorbidities throughout the country is about $30,000. With major comorbidities, it's about $40,000, of which the surgeon's fees is $1,300. The surgeon's fees varies depending on location. Medicare pays a higher rate in major cities where you get a cost of living sort of increase. So it goes, there's a plus or minus, there's a 30% variation. So in New York City or in Boston or LA, we get compensated at the highest rate. And for that, for total joint replacement, a hip or a knee, is about $1,300. So like Sioux Falls, South Dakota, is one of the lowest compensated places. They're getting $900. So when you look at $900 or $1,300 versus the episode cost, which can be $30,000, $40,000, it's about 5%. So it's really not much. And even Medicare Part B fees for consultants, I mean, if the cardiologist sees a patient in-house, they'll put a bill down and they'll get paid probably $100, $125, which again, when you look at the whole episode of care, is not that much money. The problem with the orthopedic surgeons are they're the ones that control the care of the patient, right? So they can leverage a lot of costs.
Well, thank you very much for that response. We're getting a lot of great questions, so we're just trying to move through them, as many as we can. And the next for you, Dr. Bosco, is what is your opinion on how and when surgery centers will fit into the ortho bundle?
Well, surgery centers are are already very prevalent for the commercial bundles, right? So what groups of orthopedic surgeons are doing is they own their surgery centers, and they're, I hate to use the word cherry picking, but they're taking their commercial patients, young, healthy patients, and they're doing their total joints in their surgery centers. And for instance, total hip replacements, outpatient total hip replacements is a reality. We've done over 300 of them here. You have to have the right patient, right? They have to be healthy and young, but they're easily done at a surgery center and go home the same day. A lot of ambulatory surgery centers that are physician-owned have 23-hour stays. So even knee replacements, you can do them, and they stay 23 hours. They're going home the next day. So the bottom line is private practice orthopedic surgeons have really been doing commercial bundles and taking patients to their surgery centers. Now, hospitals themselves, Medicare patients can't be done at a Medicare total joint can't be done at a surgery center. You will get reimbursed at this time. We all think that within a year that's going to be changed because it's been demonstrated to be quite safe to do a Medicare total joint replacement as an outpatient. They just have to be compensated for it.
Well, thank you very much, Dr. Bosco. And then the next audience member wants to know, has your group set up any partnerships with post-acute providers, either informally through simple agreements or formal contracts, like internal cost savings, et cetera?
Yes, that's another great question. So we talked about post-acute care, right? So we try and establish a narrow network. So we try and limit the post-acute care places where our patients can go. So 5 years ago, 10 years ago, before all this, you know, when a patient is ready to go home, we say, or be discharged, say, just have your family pick out a nursing home or a SNF, a nursing facility, and just let us know which one, and we'll get our social workers on it. We'll get them admitted. Now we say, okay, you have your choice of 3 or 4 of these places, which we have relationships with, because we actually wrote a paper with Illinois Bone and Joint, because they're in BPCI as well. And it's funny, they got cost savings just like we, in the same, basically same percentage, but they really didn't reduce. They achieved their cost savings not by reducing the percentage of patients sending to outpatient, inpatient rehab, but they did it by decreasing the length of stay. Right. So, for instance, the way inpatient rehab or SNFs work is that basically it's a per diem rate, and patients usually get approved for 21 days stay. So if you're getting a per diem rate and you're approved for 21 days, every patient's staying for 21 days. Because if that nursing home or SNF lets the patient go at 10 days, they're losing 11 days of a per diem rate, right? So they've always been incentivized to keep the patients for 21 days, when the patients don't need to be kept for 21 days. So if you go to a narrow network and have agreements with you guys, say, listen, we'll send our patients there, but you're not gonna keep them for 21 days. We want 10 days. They'll do it because they don't have a choice, and that's what Illinois Bone and Joint did. Their percentage of patients going to SNFs really didn't change, but their average length of stay went from 20 days to 12 days. So they saved a lot of money as well. So narrow networks is very important in this, to answer your question.
Well, thank you. And the next audience member wants to know more about gain sharing. And their question is, have you entered into any gain sharing agreements with other providers? And are you aware of the amount of activity going on with gain sharing? Yes,
I'm quite aware. And no, we don't. We only gain share with the orthopedic surgeons, because they're the ones that really control. I mean, the anesthesiologists, we're not gain sharing with them. They're employees of the hospital. We're not gain sharing with the cardiologists. We're not gain sharing with the hospitalists. Only the orthopedic surgeons, because they control. You know, it's still their patients, and they can control with prosthesis. The patients still trust and listen to the orthopedic surgeons. So if the orthopedic surgeon says, listen, you're right. You went to a rehab place 3 years ago, and you should go to a rehab place now. That patient is going to a rehab place. They're not going to not listen to their orthopedic surgeon. But if that orthopedic surgeon is aligned with the hospital and aligned with the gain sharing and realizes it's in the patient's best interest to go home and spends an extra 5 minutes with that patient saying, you know what, it's in your best interest to go home because the outcomes will be better. Your your infection rate will be less, you'll be happier at home. I know you have some fears and apprehensions about that, but you talk to our social worker or clinical care coordinator before you have your surgery, and they'll work through these fears and work through these issues that you have. But that takes time and effort on the orthopedic surgeon's part. And why should an orthopedic surgeon alter how they practice just to save money if they're not going to participate in that savings, right? And the government understands this. It's not a bad thing to gain share with physicians.
Well, thank you very much. And it looks like we have time for one more question, and that is, how are you collecting the patient-reported outcome?
So that's another thing that really requires an infrastructure. So we have we send patients for our physicians, our attendings that aren't part of our aren't employed. We send their patients letters, which they send to us. For our employed physicians, we work at one large center, and we have iPads. When they come in, they fill out the iPad before they see the physician. So that's how we're doing the pros there. We have over, I think, 120,000 unique patient visits in the past 2 years, 3 years. So, it's difficult when your physicians are scattered, but when they're centrally located, it's a lot easier. And that's how we're doing it.
Well, thank you for that information. And that is all the time that we have for today. And I want to once again thank Dr. Bosco for his excellent presentation, and to our audience for all of their participation today. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.
Thanks, everyone. Have a good day.